So our agenda for this morning, we'll start off with a very few slides from myself and Jenny in terms of national update. Then we've got Di Kitson speaking about the survey, feedback on local IAPT services and the report that was done for Wessex earlier in the year. Sam Angelo is going to be talking about IAPT and what IAPT offers. And then we've got Manesh Kashu who will be talking to us about what's culture got to do with it and linking nicely to thinking about our system-wide working and moving forward. Okay, next slide, please. And next slide again, please. So in terms of updates, I just wanted to bring to everybody to the attention of everybody, the Black Maternal Mental Health Week is this week. It's running all week and it's the first annual awareness week which highlights Black women's mental health and is organised by the Motherhood Group. There's a series of articles, videos and host discussions being done over Zoom and social media. The hashtag is on the slide here and we'd just like to refer people to that. There's some really great stuff on there, so it's well worth a look. Can we just ask you to mute yourselves as you come on? Thank you. Can I have the next slide, please? Now this is hot off the press from Best Beginnings. Some of you may have seen it was circulated from the regional team yesterday. This is an offer in terms of free support to pregnant families and new parents during the COVID period. Our understanding is that it is time limited support, but there's a whole host of information on their website. So again, well worth paying the website a visit and seeing what's on offer, but some really good stuff. And we hope that we might be able to get them to speak to us at one of the future webinars. Okay. Next slide. There are currently also the National Positive Practice in Mental Health Awards. I've been on the website and I haven't managed to find a deadline for this in terms of when the submissions need to be in by, but I think there's so much good practice going on within our region that I would encourage you all to have a look at that. There is a specific criteria for perinatal mental health section, but there's also lots of other things in terms of COVID-19 innovations and that. So we would encourage you to think about the best practice work that you've done, that you've shared on these webinars, and think about putting yourselves forward for some of these awards. Or else, if you would like to nominate somebody, you know, also let us know and we can think about doing that on your behalf as well. Okay. So my last slide today is with regards to the survey. Now we advertised this back in early summer, I think it was. The survey continues, but I guess what I would like to draw to your attention is that my understanding is that there has only been one submission, certainly from the Hampshire Thames Valley area. I can't comment in terms of the Kent, Surrey, Sussex area, but the information that they receive, that, you know, they can only draw on the limited conclusions that they get due to the sample size. So we would really encourage you to fill out the surveys in order to get, you know, to be able to pull better conclusions from this. They will continue to explore trends in managing risk and look at the evidence base as well. And there will be a deep dive on all the results as planned for the next national network meeting. And when we have them, we will bring them back to you. But I guess it's a bit of a plug to say, please fill out the survey so that your data can also be included and feedback in that. Okay, next slide, please. So just a quick mention before I move on and hand over to Jenny, but just to say a big thank you to all of you out there in the system that have been working on your maternal mental health services bids. We know that it's been a big piece of work to get done in the timescales that you have had, and we appreciate all the work you've done in bringing your systems together to do that. And at the next webinar, we will be feeding back in terms of the results of the bids. The panel's being held next week on the 8th of October. So we will be feeding back to obviously individual systems after that, but we will bring something back to the next webinar. But thank you for all your hard work. Right, I'm going to hand over to Jenny, who's going to do whole system working.
Hi everyone, good morning. So today I want to start some discussions, and we're going to be revisiting these throughout the coming webinars on system-wide working. And I know that a lot of you on the call will be thinking, well, we're doing that anyway. And of course, perinatal has a really complicated pathway. Can we ask joiners to mute themselves, please? Thank you. Yeah, so bear with me. So what I noticed through the first wave of the pandemic was how quickly frontline staff were able to adapt to new ways of working. And it was really lovely because you just cut through the artificial organisational boundaries and really and truly put the service user at the heart of everything you were doing. And it was really lovely to see. And then as we started to pull out of lockdown, I also noticed with a bit of a heavy heart how quickly these fantastic new and novel things that you were doing kind of started to disappear again because of the demands of your individual organisations and everybody becoming a bit more sort of target focused again. So, but I don't think it's ever been more important for us as perinatal mental health stakeholders to think about how we interface with other services. The long-term plan is really going to affect what we know as our current boundaries and thresholds, and of every service that's represented on these webinars. So with this in mind, I wanted to introduce you to the first draft of an infographic we've started to create to help us all to start thinking about some of our traditional, more linear pathways and maybe rethink how we've been working. So here's a first glance, if we can just move on to the next slide. And I'm hoping that I'm not going to labour it now. I'm hoping we're going to have some time at the end of today's webinar to discuss this and for you to help us to shape it, because this is very much a first draft. And it may be something that we're hoping is going to be helpful for you locally to use to help those discussions about thresholds and how we're going to work together under the long-term plan. Okay, next one, please. So last time, so obviously today is about how IAPT fits in with the perinatal pathway. And we did do a shout out for some best practice examples. Now, because we're tight for time, I can't labour on these, so I'm going to whiz through them quite quickly. But a massive thank you to everyone that sent them in. And obviously you'll get the slide pack so you can read them at your leisure. Okay, so next slide, please. So we've had a response from Buckingham where they are successfully working with their talking therapy service to co-produce postnatal wellbeing groups, and there's a lot of information on this slide and contact details about that. So thank you to Bucks. Next one, please. And again, Southern Health working with iTalk and Talk Plus to co-facilitate their Knowing Me, Knowing You groups, and they've moved virtually as well, really successfully during COVID. And there's contact details there for Dawn if you want to know any more. And thanks to you for sending that in. And then at Portsmouth, there's a unique referral process for midwives. There's also Talking Change, we're seeing women face to face within maternity settings. So I think that's a really exciting development. Okay, next one, please. And thank you to Portsmouth. And with Talk Plus, again, they're co-facilitating groups, doing courses by the webinar, and up until lockdown, attending local baby weigh-in clinics to maintain a presence. So fantastic, that real sort of crossover, thinking outside of the box. So thank you, Talk Plus. And I believe we have another one, and Berkshire, who have a really well integrated service with IAPT. And there's a lot of detail on this slide, and unfortunately I can't go through each bullet point, but I definitely think if you're wanting to, if you're an IAPT service wanting to integrate more with perinatal, or for your perinatal service really wanting to reach out to IAPT, I definitely recommend getting in touch with Sam and the Berkshire team, because they've got a lot going on up there that's really great work. So thank you to Berkshire. And next slide, please. So now it gives me great pleasure to introduce Di Kitson, who we commissioned when we were still operating as Wessex. So just before we became Hampshire Thames Valley, Di did a survey for us on the interface between IAPT services, perinatal women and midwives and health visitors. So I'm going to hand over to Di, who's going to tell us the results of that work.
Hi, hopefully everyone can hear me. Okay, next slide, please. Correct. Okay, so as Jenny said, I'm Di Kitson, and I'm just going to spend the next 15 minutes feeding back to you on the survey that we conducted. It was actually done really last winter and completed in February for obvious reasons. We had to feed back. Next slide, please. Can you hear me? Yes. I think most of you are more than familiar with this triangle. It's just a reminder really of how the thresholds, as Jenny's already mentioned, are changing for treatment of perinatal women with mental health issues. And also it's a reminder of all the different services, a very easy reminder in a diagram, a very easy reminder of all the different services that are involved in the care of perinatal women. Next slide. Okay, so what happened was why the surveys were set up. So the clinical network identified that midwives and health visitors appeared to be unsure about what IAPT services could offer for women. And so in the light of that, the query really was, how are IAPT services explained to perinatal women in the maternity services? And subsequently also, what are their experiences? And, you know, is there anything we can learn about how they're explained and what the process and progress is for women going through to IAPT services? Next slide, please. So what we decided to do was an online survey, which is an easy way of doing things, really. We developed this survey with input from Hampshire Lantins and MSLC, or Maternity Voices, who gave us some feedback on the wording we were using, and also some ideas about things we should include. So we invited women to complete the survey, either if they had used or even if they had been recommended to use IAPT services. And we then talked to maternity professionals through a separate survey that we did. So we developed the survey through SurveyMonkey, which is a very easy way of doing things. And it was a mixture of open and closed questions. And we just did a shout out through various sort of local voluntary sector organisations. We put the link online and asked people to complete the survey. I then, I'm going to say infiltrated, but that isn't really quite correct. I then asked a lot of Facebook groups that were relevant if I could put the link on through their Facebook account. So these were things like sort of generic parent groups, single mum groups, LGBT groups, NCT groups, voluntary sector groups. Panda were very helpful to us at this point as well, and publicised this for us. So it was a good way of reaching, if you like, a sort of wider group. And it's at this point I need to say very clearly that this was not academic research. We're quite aware that this way of doing things will give a bias. The type of people who might respond to this are the type of people who are using digital platforms and social media, and that might exclude quite a lot of people. And the other thing to say very clearly is that we were looking at a broad sweep across the IAPT services. What we didn't do was compare IAPT services. So there's no sort of naming of IAPT services throughout the paper. It's actually just looking generally across to see what people's experiences were. Okay, right, next slide, please. So, okay, so when it came to perinatal women's experience broadly, we were asking questions to elicit feedback on ease of referral or access to their services, what their expectations were, and then what their experience of the therapy offered was, what the challenges and barriers accessing the IAPT services, if they could identify them, and also suggestions for improvements and developments around accessing or receiving the service. Next slide, please. So the questions were, how do you access the information? What help and support do you get to access the service? What are your expectations of the service and the types of treatment available? What were the barriers if you didn't access treatment, and was the therapy helpful and appropriate to your situation? And what were your suggestions for improvements to practicalities about accessing services? So very simple questions, some quite open and some closed. Next slide, please. So where did you get the information on accessing your local therapy services? Not surprisingly, 42% told us that the midwife or health visitor gave them the information. 20% talked about their own knowledge or research. And again, that might be about this particular group of women who maybe use social media a lot. GP advisor recommended was actually quite high at 26%. There wasn't a lot about things within the clinic, so people didn't talk about flyers, posters or information. They did talk about perinatal specialist team giving them information about IAPT, and there was some minor other comments as well. Next slide, please. We just wanted to know if people actually got practical support or encouragement to access the services. The examples we gave were help with making a phone call, or did somebody do a formal referral for you? Now, the reason we put that in was because we know that women can be signposted but still feel quite anxious about picking up the phone to ring their local IAPT service. So actually 46% of people who responded said yes, they had had help, but 53% said no. So quite an even divide, really. Okay, next slide. And did you understand what to expect? Quite a large percent said no, they didn't really understand what to expect. 34% said yes. Gave more details, did say that health visitors or midwives or GPs were quite clear with them about what the process would be and what the types of treatment available might be. So there was lots of positives there. Okay, next slide. Okay, so then we just asked them what type of treatment or support were you offered. And as you can see, there's a range really across the whole board, with the biggest percentage was face-to-face. And then we had phone therapy, 27%, 12% group therapy, and then we had a few for online computerized CBT, a few people who'd accessed webinars responded, and a few people also talked about they just had advice and education. So that was that. Okay, next slide. So interestingly, it seemed to matter what type of treatment mode that women were offered. There was really not much difference in terms of satisfaction, and really sort of across the board, about 40% described positive experiences. And the sort of examples of things that were making them feel very happy with their experiences were things like appointments were made to fit in with consultant scans, creches were offered, late evening appointments. One person picked her therapist out as being incredibly flexible and accommodating, so that each appointment had to keep being changed, and the therapist allowed that to happen. And online CCBT and webinars were mentioned as helpful and flexible. And I think this is a lovely comment. I actually didn't need an assessment, but I got a friendly follow-up check-in phone call 2 weeks later. I think that's rather lovely. Okay, next slide. Next slide. Okay, so, oh no, sorry, back one. Can we go back one? Thanks. Okay, so the main themes identified. So because we asked quite a lot of open questions, there were quite a lot of themes that we could identify. And there's definitely quite a theme on the lack of specialist or specific perinatal support. And that was mostly around previous birth trauma or tocophobia. And this could be a perceived lack of, but also there was quite a lot of comments about how the assessment didn't seem to be about their situation, about their pregnancy, about their previous, much more of a generic assessment. And that might just be something about how people word things and explain the process, I guess. Lots of comments on the mode of delivery. And as I say, actually, the sort of split on this is that really almost equal on it was good, it wasn't good. Process issues, I'm afraid there were a few about they never rang me back, I had too many cancellations, I lost heart, I had to wait too long for formal CBT. So there were a few comments on that. Lack of information, not aware of psychology services. I think these would be people who perhaps had never had much contact with psychological services before, and it was all very new to them, and perhaps felt fairly unclear about it. Obviously, the theme on need for venues, flexible hours, childcare is that goes without saying. Timescales for treatment were mentioned. A few people actually talked about how they were described as not eligible because they weren't ill enough, and they were pretty disappointed by that. And one comment here, which I think is very telling, I didn't access IAPT straight away as I didn't get enough information to know what to expect. Next slide. Okay, so I just picked out some quotes here. I mean, what I would say is the actual paper is not an enormously long paper, and there's an awful lot of really interesting quotes and suggestions and things that I think would be really helpful, particularly perhaps for perinatal champions in each IAPT to look at. I think, you know, it really does tell a story, and a story that I don't think will be a terrible shock to people, but I think is a reminder of what people's experiences are. So these sort of quotes are around make it more obvious that services are available. What even is it? If you've never needed help before, how do you know for? And then there is another theme about postnatal depression, well-being, positive mental state, perhaps not being, if you like, on the agenda throughout the pregnancy, and a feeling that it should be. And very tellingly, this quote, I thought people would think I couldn't look after my daughter. And that shows you that there's still a concern around the stigma. If you access mental health services, people are going to think there's safeguarding issues, etc. So that's just a very sort of telling comment, really. Next slide. Okay, so then midwives and health visitors to give us some feedback through a survey, and that was done through various closed Facebook groups, and I got lots of help from the specialist midwives and health visitor leads on getting the survey out. Actually, what I haven't said that I should have said is we had over 120 responses to the service users, as I would say, response. And for the midwives and health visitors, the maternity professionals, we had over 50, I think it was about 56 responses. So we were very pleased with that response, and it shows how easy that digital, quick, instant digital sort of shout out can be. Okay, so we were asking their experience on referring or just signposting, knowledge of what's available, feedback from services or any other communication they have with IAPT services, and ideas for future improvements or developments. Next slide, please. Okay, so the questions were very straightforward. Most of them were open, actually, so we got a lot of a narrative here. Do you signpost or refer women? Do you feel informed? To give detail to perinatal women, Are there any barriers that stop you referring? Are you aware or confident that perinatal women are given priority in your local service? Are you aware of any specific support? What is your experience of feedback from the service and communication? And what are your suggestions for improvements to interdepartmental communication? And as you can imagine, we had a lot of suggestions, really great suggestions, actually. Next slide. Okay, so this was just an interesting one. Post or refer perinatal women to your local services, and obviously huge majority probably just give women information and get them to ring or contact the local IAPT services. Small number refer, and obviously nearly 20% of maternity professionals probably choose whether they would signpost or refer according to what they see in front of them. Okay, next slide. Okay, so 58% of maternity professionals do not feel informed to give detail on what types of treatment or therapy or timelines might be offered or how the process works. That is actually quite a large number. If I was clearer, I mean, this is a great quote. Clearer on what therapies, timeframes, expertise available, this would make me more confident to encourage referral. Next slide. Okay, so here are the main themes that came from the maternity professional survey. Too high a threshold for treatment. This was mentioned quite a lot, that people didn't understand when people were apparently refused IAPT because they weren't unwell enough. Lack of specialist treatment was mentioned again for tocophobia. And again, this might be about models and how IAPT explains itself, but no counselling or DBT in one service. Groups weren't specific for perinatal women. And actually some of the women did talk about how it'd be great to have groups that were specifically for perinatal women. Didn't understand the pathway and how it works with prioritising, didn't feel confident about timeframes, treatment too little, too late, not enough feedback from service on women unless I ask, but also the comment on CBT feedback was really good, gives a clear picture, and awareness of specific support. Some examples were given: Knowing Me, Knowing You groups, which we've already mentioned this morning, Mums Matter, and specialist webinars were mentioned. Okay, next slide. I'm aware of the time, so I'm dashing on. As you can imagine, we had lots of fabulous suggestions from the maternity professionals. They would like to see more dedicated specialised resources, birth trauma and tocophobia. They would like better communication and feedback from IAPT, even if the happen. They'd like more clarity of pathway. I mean, there was a few suggestions that they don't even have flowcharts on wards in the clinics, and even that might help. Lots of suggestions about interdepartmental training, which I thought was fabulous. Lots of ideas for IAPT practitioner on sites, talking about things that I think, again, Jenny has mentioned already this morning. Could we have IAPT practitioners in weighing clinics or postnatal clinics? Could we have informal pop-up talks at clinics for staffs and mums, more leaflets, more flyers? Could we have education and training for maternity staff and IAPT staff together to encourage mutual understanding? Somebody, perhaps a bit optimistically, asked for a dedicated team of psychologists and psychiatrists in clinics. And some people also talk just about online training for maternity staff to improve their understanding. And I think this quote is quite an important one. I feel that having given the women the information on who to contact, we become peripheral to that service, even though we have regular access to women and could be of help in managing the problem. Next slide, please. So again, you have the professionals' comments. And again, I would urge people who are really interested in this to look at the survey and look at the quotes and the suggestions. I think this one, it feels like we're sending women into the unknown and just hoping. I'm not clear on what timescales and service guarantee is around prioritisation. And again, if I was clearer on what therapies, timeframes, expertise available, this would make me more confident to encourage referral. And there was also some talk from a few professionals about they felt the IAPT service kept a low profile because they were so overwhelmed, and that they needed a bit more marketing and profiling from their local IAPT service. Okay, next slide. Okay, so each of the local Wessex IAPT services, except one, identified a perinatal champion, and they had varying roles and responsibilities according to their locality and geography, not surprising. One of the services was able to describe how the statistics and data that was being collected about perinatal women was used and looked at by a group that met 6 weekly, and they also described trying to meet with midwives 6 weekly in their localities. And also all of the local IAPT websites do have specific information for perinatal women and mental health, which was great to see. Next slide. Okay, so I'm not going to go into too much detail of this, but it was really interesting to see what Manchester Pennine Trust have managed to achieve using transformational money. They had a whole system approach to perinatal and infant mental health, which they said had encouraged a really collaborative approach across multiple teams. In fact, all their IAPT clinicians are expected to reach Tavistock perinatal infant mental health training level, and the perinatal champions are actually offered a higher level training, so it's a fairly high standard of training there. And they've developed a RAG rating exercise for IAPT sites and commissioners, so when they meet with their commissioners, they actually check out their progress against. These are fairly obvious examples, actually. And interestingly, what they talked about in their process was how they had an old-fashioned word, how they had to normalise mental health and well-being throughout pregnancy, because they found that at the beginning they were trying to engage people in different groups that they'd set up, which sounded fabulous, but they had very low take-up, and they felt that it was to do with this issue around stigma and people being concerned that if they couldn't care for them, they would be seen as not being able to care for their children. Okay, next slide, please. So the summary from the survey is fairly straightforward. Maternity professionals feel some distance from local IAPT services, but there's such a strong interest in partnership working and more information exchange, real interest in well-being and mental health as well. A proportion of them don't feel confident about how to describe the local IAPT services and treatments. Concern expressed about local specialist resources. And the bottom, I'll just draw attention to the bottom bullet point to say negative feedback from even a few women can affect the decision to refer or signpost. And if they don't get feedback from the IAPT services, maternity staff don't feel equipped to encourage engagement. So I think that's really rather important. Next slide. Okay, again, I think it's really a repeat of the sort of things we've been talking about, really. Perinatal women also saying they didn't have clear information on or even understanding of what was happening to them as a person. A strong theme about well-being and mental health should be being emphasised throughout the pregnancy journey. Discontent with IAPT venues, lack of creches was often stated. There were comments and uncertainty on what types of IAPT therapy were and weren't available. So again, the theme that the groups offered weren't very specific to perinatal women. Helpful to some, but many felt it wasn't relevant. Okay, next slide. Aware of the time. Okay, so recommendations are results to be shared through relevant networks to understand how, again, this fits with the NHS long-term plan and how all the different services are going to work together more collaboratively, and each IAPT service needs to be fully integrated into the work of the PM programme. In some ways, it was very simple, the messages that came back to us. It was very much about communication on the ground and about those informal conversations. And obviously, when under such pressure with time limitations, that sort of informal chat perhaps gets neglected. But the idea of joint interdepartmental training seemed very strong. And also I thought it was quite important that the IAPT data, which I know you have a massive job to do around your IAPT data, could be shared a bit more regularly with local network, clinical leads, and perhaps wider on perinatal women and how they've accessed the service, etc., which would help inform the whole picture. Okay, next slide, I think is the last one. Yes, it is. Okay, so that's me finished. As I say, the full paper will be available, again, to emphasise not research but results of surveys is available, and I think I would urge particularly the perinatal champions to read it. And I also have done what I call a headline briefing sheet, which could be used by team leaders if they wanted to share just the headlines of the surveys. Okay. You know, I'm really happy to answer any questions at the end of the session, but I know we're very time limited, and I think I've come to the end of my time.
So thank you so much, Di. I think that's been such a helpful presentation, and really quite thought-provoking as well. I think some of the things we might have made assumptions about, but actually having got out there and asked questions, I think it's really, really quite provocative to think actually there's a lot of work to do. There's some great stuff going on, but if we just went those couple of steps further, we could do so much more. So thank you so much. Could I ask people if they have questions for Di that they go into the chat box? And Di, you're able to stay, is that right? So
yes, yeah, I am.
You could answer the questions if anybody puts any.
Okay.
Obviously, Di can't answer questions about specific IAPT services, but if you've got anything about what about the presentation, then that would be fab. Just pop them in the chat box. Okay. Thank you again, Di. That was lovely. So I am going to move on and introduce Sam Angelo, Quality Improvement Support Manager for Adult Mental Health, who's going to talk to us about what IAPT offers. So we're going to get like a good overview so that people can take away messages about the offer and hopefully do a bit of myth busting about what IAPT does and doesn't do. So over to Sam.
Hi, morning all. Thank you, Jenny, and thank you, Diane. I found that really interesting as a look at your survey, and be very excited to read it when it gets circulated after this presentation. So I thought I'd start today by just going a little bit back to basics to see a little bit about what it is that IAPT does offer, so that everyone can be confident in the conversations that they're having between pathways. So IAPT offers timely access to evidence-based specialist assessment and treatment, including psychological interventions in line with NICE guidance as a basic. That's a sum up all of IAPT. That encompasses quite a range of therapies, and that includes, so coming in at step 2, IAPT offers a stepped model of intervention, and that covers things like depression, generalized anxiety disorder, panic disorder, and OCD, and is treated with a range of CBT, self-help, and that's really important because it means that patients can work in their own time and complete booklets at their own pace, as well as being kind of helped by their professional rather than set appointments. Next slide, please. At step 3, we also covered depression, and that is mild to moderate and moderate to severe, despite a kind of common misconception that IAPT is only for mild to moderate depression. And we also talk about prevention of relapse. Next slide, please. We also cover a range of kind of anxiety disorders and other kind of diagnoses. So generalized anxiety disorder, as said, at step 3, panic disorder, PTSD, social anxiety, OCD, and then some of our long-term condition service can also help with things like chronic fatigue syndrome, chronic pain, and IBS, and any symptoms that are not specified. And they can do that in the context of what is going on in pregnancy as well. But as the survey kind of rightly pointed out, would benefit some specialist advice from maternity and perinatal champions. Also important is that this is all lifted straight from the IAPT manual, so you're welcome to read that. That's online, and I can circulate the link afterwards. But they also offer targeted for specific phobias, so such as tocophobia could be treated within an IAPT service. Next slide, please. So just coming back to IAPT and perinatal, so that one of the fundamental principles of IAPT is that they reflect the community and treat everyone in the community kind of with clinicians that would reflect them. So that would include parents with perinatal mental health problems. And there's a little bit more on the second and third bullet points about how, the disorders that IAPT treats as well. A large proportion of women will be appropriate for treatment in IAPT, and there's a link to the positive practice guide for perinatal there if you'd like to see what IAPT clinicians are expected to do with perinatal patients. Next slide, please. So in terms of waiting times, I know that was a theme that was coming quite strongly through your survey, Diane. Women are supposed to be prioritised for assessment within 2 weeks of referral and commence treatment within 4 weeks. That means that they should be getting the help and signposting quicker than a normal patient entering the service. IAPT services have been doing some hard work to extend their perinatal period to 2 years after birth, in line with the guidelines you have been given around perinatal. And there is an expectation that IAPT services do have a perinatal champion. We've got lots of training, hopefully coming soon, on board with that to further specialise some of the IAPT clinicians' knowledge, which should be really positive. IAPT does treat PTSD and could help with birth trauma. But as Diane's slides also rightly kind of drew out, is that we need to actively encourage engagement with yourselves and with the perinatal pathways. So IAPT clinicians are not necessarily the experts, and they are tasked with dealing with quite a wide range of problems and kind of different presentations in different kind of minorities or specialist groups, as it were. So it is really important that we work towards engaging with our perinatal services and making sure we are getting specialist medication advice, specialist advice from the perinatal mental health team. What I also thought was really worth mentioning is, given COVID, one of the positive things for IAPT has been a move to online. Benefits and drawback, but it has increased flexibility greatly, and it means that a lot more people now can access appointments within their own home, which can be useful when you've got childcare kind of issues at the same time. And I was pleased to see that one of the things came up with was the understanding of IAPT professionals around the need to work around what people have got going on in their lives. And this would apply obviously to perinatal women as well. Next slide, please. So this is straight from the positive practice guide, but I just wanted to draw out a few barriers that it talks about for perinatal mental health problems, and how IAPT could help some of those barriers. So the wish not to cause a fuss or bother or burden the busy GP. A significant amount of referrals from IAPT are self-referrals or kind of directed self-referrals, as we sort of started to see in Diane's slide as well, where someone else has advised them to go and self-refer. It means that people can do it in their own time and don't have to worry or feel like they are a problem to their GP. It also, IAPT is quite clear that they treat adults and they treat you, rather than having kind of a badge as being anything to do with CYP services, and this can help in that mothers are worried about that being investigated by child protection services or worry about the stigma associated with them. Next slide, please. I just wanted to talk a little bit about exclusion criteria, because I think there's a general kind of worry about IAPT bouncing people back, and as we can see from some of the data earlier, that is the case. So if we can inform everyone, that would be really great. So a person's involvement with secondary mental health care does not lead to automatic exclusion from IAPT. The general principle is that IAPT can work if they can treat most of the problem with some advice from other professionals. They will accept referrals. They also take advice from other professionals in treating more complex presentations, but it's definitely not an automatic exclusion. People with multiple traumas also are not routinely excluded from IAPT services. As you can see here, it's suggesting that IAPT services can work with people between 1 and 3 traumas that result in intrusive memories. And also, I mentioned briefly this earlier, but that people with moderate to severe depression are treated across all IAPT services, despite people thinking that IAPT services are only appropriate for those with mild to moderate depression. So there's some work that we need to do in terms of marketing to make sure that everyone knows that that is the case. Next slide, please. I put on a little bit about local provision, but you had some fab examples at the beginning of the webinar of what services have got in place, and this is slightly out to date, and I can see Giselle in the chat, so please do correct me if any of this has moved on in Surrey. Surrey did some really good work with working together and creating some pathways for their perinatal patients, and I wanted to pull out the POWER, Pregnancy Orientated Wellbeing Empowering Resource Group, the third bullet point up, where a comment was about a low number of referrals being received. So again, it's just reiterating from both sides that there's a keenness to work on the referral pathway and how that they can improve that. As I said, the perinatal champions are very engaged, and the perinatal patients are prioritised across all providers for appointments. And all of the services in Surrey reported having a perinatal champion in place. So it'd be good to get, perhaps we can work on a list of contacts for that as well. Next slide, please. We rightly pointed out earlier the data burdens on IAPT, and it seems a really great idea to me that we should be using that data in the most kind of efficient way and sharing it so others can benefit of it. So the IAPT version 2, which is what they are required to collect, went live in September after a few delays, supposed to go live in March, and it does ask basic questions like, are you pregnant? Is your partner pregnant? Do you have a child under 12 months, under 24 months? Some services are willingly submitting to the matrix of perinatal mental health as well, because they said it's quite easy and beneficial to do. PHE has a lot of data on its website for the fingertips tool, and I've just put a link to it there, and that's a little bit about prevalence of some indicators in our southeast area. I thought that was an interesting TC, so do go on and have a look at that. Next slide, please. Jan, next slide, please. Thank you. So I put a few bullet points here about what could help. As we've said and talked about normalising, I've used the old word as well, of experiences are powerful tools. A kind of reflection on the competing demands on IAPT, that they have a lot of different services kind of struggling to have their cohort of people heard. So anything we can do to make the perinatal voice louder in getting them set up and sorted. Pathways work again. Access, the ambitions on IAPT for access are really quite large over the next 4 years. So I think any kind of help that they can be given to direct patients into them will be received with welcome arms. Again, the need for specialist advice, that the IAPT clinicians are not always the specialist area in something like perinatal. The flexibility to make sure that we've sorted out how someone can be passed on and referred, and a little bit of widening the lens for IAPT. So if there's any help that we can offer in terms of thinking about with parents how they talk about the relationship with the child, it's typically adult IAPT has not had a lot of training around that knowledge, and it would be good to see if we can extend that. I think that's me done, Jan. Yeah. So that was a really whistle-stop tour through some of the areas that IAPT offers, but I'm happy again, Jenny, to stick around for questions at the end if you're tight on time.
That's fantastic, Sam. Thank you so much. I think that has really complemented Di's presentation and really gone a long way to sort of bust some of the myths around IAPT services. Looking at the Surrey example, as well as the examples we had earlier of best practice, what fantastic work's going on out there, and what, you know, if we could pull all of the stuff together, what amazing services we would have. And that's very much where we want to go with these webinars, is just making sure everyone's aware of best practice and see what they can do to move on their own services. So thank you so much for giving us that overview. And again, could I ask if there's any questions to pop them in the chat box so we can move on. And I don't know if anyone's on the call from iTalk, but I see there's a question about iTalk in the box, if somebody can answer that for us. So without further ado, I'm going to hand over to Minesh, who is the Maternity Clinical Advisor and South East Region Safety Champion. And Minesh is going to present a talk which I've seen before. And I think this is a really inspirational talk and a great place to start thinking about working in different ways. So with pleasure, I'm handing over to Minesh.
Thank you, Jenny, and thank you, Liz, for inviting me to speak to you all today. And thanks, Sarah, for doing the slides. So those of you who don't know me, which is perhaps a large section of you, I work at Pool. I have lots of different hats, which I'm not going to bore you with. But to start off, because you look after other people's mental health, let us, through the chat, using emojis or using thumbs up or thumbs down, just tell me how you're feeling this morning. And then we're going to talk a bit of business as well. Next slide, please. So this is quite a busy slide, and actually this is quite an old slide which talks about how we're going to achieve everything system-wide by 2019. And obviously we haven't achieved even half of it. But it's a useful slide to go back and I would focus your attention on the second row, which talks about activities, measurement, learning, capacity building, leadership, culture, and innovation. And I'm going to spend the next 20 minutes or so largely focusing on the last three, specifically a bit about culture and innovation. And that too largely in the context of what happened to the culture of the NHS through COVID. So that's quite a specific area I'm going to focus on. But this is a useful slide for us to look at. And this is also, I guess, evidence that slides, documents, arrows don't do the work. The work is done by people and by relationships, and a lot of those relationships are informal. And unless we realize that pieces of paper don't get the work done, we will never achieve the goals, and that's why we're quite far behind where we need to be. Next slide, please. This is again an interesting slide, actually quite a comprehensive slide. I'm not going to go into detail. This will be shared with you. It's not my slide, and as a guru in quality improvement, my mantra is beg, borrow, steal, because improvement is largely about learning from others. So have a look at the slide at your leisure, but it's quite comprehensive in terms of what needs to be done at the system level, because Jenny had told me that your focus today was largely system level working. So have a look at this in more detail within your teams at individual level. And I think it's quite comprehensive. You'll find it quite useful if you wanted a big system-wide picture. Next slide, please. This is a slide actually from the US, so some of the things necessarily don't apply to us, but it's a new concept about something called systemness. So if you're looking about systems, and the question you need to ask yourself is, how is the systemness in your system? How cohesive are the linkages? How well do people work together? How well do the different elements that are important for the patient work together? So in the center we have systemness, but the systemness should be the center always should be the patient, the client. So systemness from a client perspective, I would urge you within your own systems, within your own teams, maybe explore this in a bit more detail. I don't have a lot of time today, but I think it would be quite useful for you guys to look and evaluate what is the degree of systemness within your system. Next slide, please. And I'm going to focus largely now on improvement innovation, which is an area of interest for me. And perhaps a good place to start is what is the most important prerequisite for innovation improvement? Why does it happen? How does it happen? And I think I have a very clear belief that the most important prerequisite, which is the next slide, is, next slide please, is people. It's you guys. So unless we have passionate people in the system who want to do better, we can't get anywhere. And I think that is the treasure. That is what we need to be celebrating. That's what we need to be focusing on. Next slide, please. So once we have passionate people at a system level or an individual or a team level, there need to be three key realizations to generate improvement. The first realization is care is suboptimal. So unless we realize that our system, our care at the moment is suboptimal, there's no way we're going to improve. The second step in our head needs to be that we can and should play a role in improving care. And this is not about just people on the call today. This is not just about one or two people. This is about the whole team thinking that way. And then the last bit is that we realize that we have the skills to improve care. We may not have all the skills, but then we can go and get the skills. We can learn, but we generally have a lot of the skills that we need to improve care. Next slide, please. And the problem with change and improvement is that while a lot of us in our teams or at system level will want change, but then if it means us changing, our teams changing, our hospital changing, our service changing, then we don't have a lot of takers generally, which is normal human behavior. And to negate that, to go beyond that, we need, next slide please, we need leaders. So this is a very good definition of leaders from one of the professors in Harvard, which is leadership is about putting people who need to change in the unavoidable path of learning. And it's not people who need to change, it's everybody. Everybody needs to change and get better every day. That's the whole point. Next slide please. I'm just listed there again. I'm not going to delve into detail. These are some of the key barriers to successful quality improvement. You guys all are trying to do quality improvement on a daily basis. So I think it will serve us all well if we focus on some of those key areas. Next slide, please. This is what I call my magic slide. I do a lot of quality improvement and change management work based on this slide. And this slide is divided into three parts. The top bit is about trying to explore the problem, and you can use it in any problem you want to solve at your individual level, at your system level. So the top bit is about how you explore the problem. The middle bit is about how you interact with that problem. What's your response to that problem? How do you emotionally connect with that problem? And the final bit is about the action bit. Next slide, please. And then I have highlighted two key areas. What keeps you from solving the problem? Are you going to be part of the problem or part of the solution? And these things are largely related to culture. These things are largely related to culture. So a lot of the problem solving has to be done through the understanding of culture. Next slide, please. We have lots of studies which show how organization culture or system-wide culture impacts. I'm not going to go into detail. You can read through this. Next slide, please. But it's quite important to understand there will be, and if you guys haven't noticed, that's actually Jenny in disguise. This is what happens all the time in the system. This is what happens all the time in the system. And despite interruptions, despite people distracting you, you have to have belief in what you think is right for the patient and get on and do it. Next one, please. And if we want to generate more innovation, more improvement, there has to be at system level an ability to take risk, learn from failure. You have to give people time and energy for innovation. You have to nurture diversity of opinion, focus on collaboration, and also largely in terms of the systemness that we talked about, there has to be a philosophy of trust. I'm not going to deny it. there needs to be innovation improvement training. You need that training to understand some of the nitty-gritty of how this will work. Next slide, please. Again, I'm not going to delve into detail. This is quite a busy slide, but I just want to focus on two bits, which are the underlying bits. So if you look at what happened during the COVID pandemic, which Jenny highlighted, that suddenly boundaries went away, suddenly we achieved a lot more at pace and at scale. And the reason was some of the external controls went away. And there was a focus at system level, at national level, to get an end sorted rather than worry too much about the means. And next slide, please. Yeah, go ahead, Sarah, finish it all off. Yeah. Go ahead, Sarah. There's one more, I think. So basically, we as a system, through the pandemic, got pushed to a corner. And what happened was innovations were initiated locally. They were not induced or dictated from the top. Because the system had not much choice left, you didn't have people in ivory towers telling you what to do. You got on and did what you thought was most appropriate to get things done. Next slide. And that's why it's a very well-known saying, necessity is the mother of invention. So the necessity of the pandemic made us do much better, much quicker innovation than we perhaps would traditionally do in the NHS. Next slide, please. So what I'm trying to allude to you here is, which a lot of people perhaps haven't realized, that what happened during COVID pandemic time was that we created a new type of culture within our systems and organizations where the focus moved away from compliance, focus moved away from national diktats necessarily to more local commitment. People locally had informal relationships, got things going, did transboundary work, and generated almost like a new culture, even though it might be transient, to make things work for the patient. Next slide, please. And this is a paradigm which we describe as an open innovation paradigm rather than a closed innovation paradigm. I'm not going to delve into detail. These slides, as we know, will be shared, so you can read them at your leisure. Next slide, please. And again, we moved from a paradigm of change programs, which was like the maternity transformation program, the perinatal mental health programs. We changed the programs into platforms. What happens by changing programs into platforms? You get people interacting, you get everybody at the table, you get the voice of the patient, you get the voice of the public, you get much better diversity of thought. And role of formal leaders is to create the conditions and get out of the way. So this is what we call servant leadership. This is what we call their leadership. Is the leaders in the system have to create the conditions and get out of the way for other people to get on and do the work. Next slide, please. And one of the reasons this works well is you can't manage success by remote control, because success is not a straight line. There's lots of changes people on the shop floor in the front line have to do to make things to work. You don't have time to do it by remote control. Next slide, please. And again, coming back to my magic slide, what keeps you from solving the problems that we talked about, that we heard in terms of the feedback? Next slide. A lot of the problems are this. There's too much bureaucracy in the NHS. And unless we bust the bureaucracy, we're not going to get improvement at the scale and the pace that we talk about. Next slide, please. So I guess the mantra in a lot of ways is just do it. Next slide, please. I have developed a model, and as part of that model, one of the things we talk about in terms of overcoming barriers to improvement is the 4 C's. Just finish off the slide, Sarah. Yeah. And the 4 C's are largely about culture, which we talked about developing capability. At the end of the day, improvement, you have to have capability within the team. The next bit is capacity. If you don't give people the time to do some of the improvement work, it's not going to happen by magic. And last but not least, it's about good communication, good two-way communication, so that people are clear what is required, how it's going to be done, who is going to do it, by when. So remember the 4 C's when you're thinking about any of your improvement projects. Next slide, please. Yeah, finish off the slide, Sarah. And again, a large part of, yeah, keep going, Sarah. Seem to be stuck on that slide. Sarah, can you keep going on the slide? Yeah, a large part of the culture and leadership is about giving headroom to each of you guys to be able to think and do the stuff you feel is most appropriate for your patients. Next slide, please. And some of it is not fancy stuff. While a lot of people think about new therapies, early detection, prevention, a lot of the good work is about simple stuff, how we communicate with patients, how we do the simple things right so that patients can get the care that they need. Next slide, please. I'm going to let you read this because I think this is the crux of what we are here to do as a job. But this is only one side of the coin. The other side of the coin, next slide, please, is the people you work with, is the team. I think the team bit is quite important, because without the team bit, without respect for each other, without understanding the multi-professional nature of our work, which is healthcare, we will not get very far. Next slide, please. And when you're talking about interventions, I think I need to focus a bit on here is the effectiveness of interventions is quite interesting, because this is an area of interest for me. So if you look at the bottom, education and training is quite low. It doesn't take you far enough. And then you go to rules and policies, then you go to checklists, then you go to standardization, then you go to automation. And a lot of the real magic happens with forcing functions. Forcing functions, an example of forcing function is the way a medicine bottle will not open because of a child lock. So that's a forcing function. So think about your system and ask yourself, what are the ways we can force people, force with an inverted commas, to do the right thing for the patient? And that's what's going to work at pace and at scale. Next slide, please. And you don't have to have everybody in your team, everybody in your organization do this stuff. You can start small, because it's a small group of people who can make the change. It doesn't always have to be everybody on board right away. They will. Once things start moving, a lot more people will come on board. Next slide, please. And it's not an easy road. There's no shortcuts. It takes time. So I think as long as there's clear communication, there's clear milestones, this will take time. This will test you. So keep going. Next slide, please. But you can't change the world unless you are ready to change yourself. So we all, each one of us, has to think, how can I change a bit so that it's perhaps easier for the patient, so that it's perhaps easier for my colleague. So I think it has to start with us as individuals. Then we can go to teams, then we can go to organizations, then we can go to systems, and then we can go to the country. So I think it has to start with us. Next slide, please. And don't worry about failing. Thomas Edison has the highest number of patents in history. highest number of patents. And even one of his most famous discoveries or inventions, the electric bulb, it didn't happen right away. He says 10,000 ways it didn't work, but he kept going. And that kept going is the important bit. There's a lot of potential in all of us. And we need to try to realize that potential, not just for ourselves, for our families, for our teams, for our colleagues, for the larger societal good. Next slide. And in a lot of ways, when we get things done better, it becomes a habit. Excellence in a lot of ways is a habit. So let's get better day by day and make that a habit. Make that a habit. Next slide. And you'll be pleased to know this is my final slide. I'm happy to answer any questions either now or later. Feel free to contact me. And thank you all for doing all the great work that you do.
Wow, Manesh, thank you so much. As I said, I've heard that before, and hearing it a second time was even better, actually. I didn't sit here thinking I've heard this. I sat here thinking, how can we make it better? So thank you. Thank you very much. And I can see from the chat box that it's had the same effect on a lot of the audience. So brilliant. I think if people have any questions, we have just a couple of minutes, and then I will try and get onto the infographic, if we can just get our heads back to that. So has anybody got any burning questions for Manesh before we move on? No? Okay then. So let's move on to end on a bit of an interactive session, going back to looking at our infographic and thinking about everything that we've heard today. So I would say this is a first draft, and it can still very much be adapted, or it might be something, if you find an image useful, that you can have to use in your own teams. But it's trying to show, and the message we are trying to do is that we shouldn't be thinking in terms of linear pathways with patients or service users using, being referred to one service. Oh no, you're not for us, you'll need to be referred over here. How can we make it flow? How can we make it as easy as possible for the women? What about when they need multiple services? And people like our health visitors are often there right across their journey, and GPs as well. So, but sometimes those people can be marginalised if we're not all communicating. So how can we just work better to properly keep our services with the woman and the family in the middle? So any comments that you have about what should be on here? We deliberately haven't put in any third sector because sometimes that can be quite local, and we thought if you want to populate it yourself, if it's helpful, then that's for you to do. But also sorry, I have to realise I'm rabbiting on, and there's a couple of hands up. So let me go to the hands, and there's Kelly. Kelly, do you want to ask a question?
Yeah, hi. Kelly Pearce, consultant midwife at Western, and I'm the incoming head of early help, moving over to Portsmouth Solent very shortly. Couple of points on the infographic that I'd like to add. I think it's great, and I think it's obviously follows the colour system that we're all used to. I think, you know, I raised a point earlier in the chat about all age, and I think that this is something that is really, really important around the under 18s. And under 18s, you know, it's so challenging for midwives and health visitors and those in FNP to know how to best support young people with their mental health. And constantly, you know, referrals go off to CAMHS, and CAMHS say they've got no specialist sort of perinatal mental health provision, and IAPT is very variable across the country as to when they'll see and if they'll see under 18s, and many are starting to start from age 16, but we've still got young people having babies at 14, 15 that are the most vulnerable, and you know, and really are being bounced between services. So I think it's really important to understand how this infographic makes a suggestion around age. And the other point I want to make is around early help and how we are interfacing with early help around people's mental health. So I think that I couldn't see early help on there, but it's quite small, so it could be my eyes. But yeah, I felt that was really important from a whole system approach.
Okay, well, Yvette is on the call as well, who's been working with me on this, so Yvette will capture that. Do you have any ideas, Kelly, as a bit of an expert in the field, how we could best represent the age span?
I think it's difficult, because it's about what we decide as a system, how best to support young people. And obviously FNP obviously has some real targeted support for young people, but isn't necessarily offered to every single young person. So I do think that it's about how we are developing services. And I think at some point, like I've been probably banging on for the last 10 years about under 18s, and I almost feel like we're waiting for young people that are pregnant or postnatal to die, unfortunately, before anyone actually does anything. And I really do think that this is something we have to nail and decide who is offering perinatal services to under 18s. So yeah, it's just really a challenge to us all, really, as to how we can overcome that barrier. I haven't got a solution myself individually.
Okay.
I do also think that there's a lot of I guess, you know, if I'm going to be really courageous and put it out there, I do think that there should be more opportunities to look at midwifery, healthy child programme and IAPT services working more closely together, perhaps in integrated teams. And certainly that's something, once I get over to Portsmouth, that I'd really like to try and look at further. So, yeah, I think it's in our gift to look at other ways outside the box of how we can try and best wrap services around the family rather than pointing them in different directions.
Brilliant. That sounds fab. Okay, so I think, Gisela, you were the next in line. I'll go through the people that have got their hands up at the moment. So over to you, Gisela.
Thanks, Jenny. Just a quickie, not to forget, you know, partners, and in Surrey, you know, we've gone to 24 months now, perinatal partners being prioritised, you know, with women as well. I think that's important. We work with the Mindful Service too, and the Trust with a link worker, a CBT Band 7 therapist who is the link person for the 16 to 25. So at the moment we can only see 17, but these would be quite vulnerable young people that potentially come through that service, potentially pregnant as well. I think the difficulty, we know that research evidence for long-term conditions is best outcomes where the services are integrated with IAPT, you know, the physical services. So we know that perinatal will probably be the same, but it's getting those relationships. And as Manesh said earlier, that culture, sometimes it's like who's in post at the time on the ground on the physical health team as to whether you'll get them to be enthusiastic enough to embed it, because the culture needs to change so that people think about IAPT as an option, you know, when they're assessing these women initially. And I think that's your difficulty, because people forget, you know, new staff members move. So you need to have that constant sort of presence, really, which is quite labour intensive in terms of resource for, say, the model that we are in Surrey, which is a payment by activity model. But even the Power project that Sam Angelo talked about, I think we spent 7 months, every single IAPT provider, 6 of us, did a whole round of winding down a Band 7 time clinic from one-to-one work to allow for that group. And then they did take off. That's 7 months work of all IAPT providers with no pay at the end of it. So what I'm saying is, you know, ladies had to be done. There was just a handful one-to-one because there wasn't enough group. So again, I think those pathways, it's absolutely critical, you know, spending that time, but it will work because I know integration is the best, but it's giving that time consistently by all the different providers. It's a challenge at the moment.
Thank you. And I think the long-term plan has thrown everything up in the air because perinatal services are going to look very different by 2023-24 than they even do now. And with the maternal mental health services coming online, I think that there's just such a fantastic opportunity to start talking about thresholds and instead of looking at artificial boundaries and interfaces with services, look at what's best for the woman and just work it out in that sort of way and just have more flexibility. So the more we can move towards that way of working, for me, the better. I think the next person was Helen. Have you put your hand down now, Helen? I thought I saw you. You were next, I think, and then Tamsin. Yeah, Helen, what were you going to say?
Hello, I'm Helen Bloomfield. I'm the lead mental health midwife from Hampshire. I just wanted to say something about, I really like that the what it looks like, but I think there needs to be maybe more emphasis across sharing of care plans between services. Okay. I repeatedly have issues trying to get women in crisis seen and supported when they are already known to other teams. So something about a really clear visual around the passing on of care plans and the sharing of care would be helpful.
Brilliant. And if we had one care plan that was moving with the woman rather than each service, something like that. So, and is there something in there as well about I'll grasp the nettle, access to systems. So I know in Hampshire we've done pretty well in midwives being able to access RIA and that sort of thing, but to just, I don't know, something to highlight data access or something maybe.
Yes, I think, definitely.
Okay, thank you.
Thank you.
Thank you. And Tamsin, you had your hand up too.
Yes, thank you. So my name is Tamsin Bowe. I'm a cognitive behavioural psychotherapist working within Talking Change, which is the Portsmouth IAPT service. And I just wanted to really echo what everyone's been saying about talking about how it's really important that we all work together and have that shared communication between services. And I'm really aware that we used to have an IAPT clinician based in the St Mary's maternity service. We also had an IAPT clinician based in community in children's centres as well, and of course with COVID that's been really difficult, having to then go remote working, and I think there's a real opportunity there for us to reconnect. And I think one of the other things we can do that, which was actually a suggestion made by Anna May, who's the specialist perinatal mental health midwife at QA, is actually perhaps we can be part of multidisciplinary team meetings, so that we can have that shared approach to care. So it's not this artificial, oh, they don't quite meet threshold for IAPT, they're too severe for us, but secondary care say, well, she's not quite severe for us. And then we end up with the people who fall through the gap whilst all this time, you know, their pregnancy is progressing and their mental health is deteriorating. So I'm wondering if that kind of shared approach might be really helpful as well going forward.
And I'm personally really hopeful that that's something that the maternal mental health services can bring to actually work across, you know, multi-agency to see which agency is best placed and to have those sort of multi-agency triage clinics or whatever it might be. I'm hoping that we'll see some of that emerging so that we can just get the women to the most effective place as efficiently and quickly as possible. And also that bit about working flexibly where they might need some therapy from IAPT, but they may also need some medication advice from a specialist team, and that we're not going to get sniffy about people being open to 2 services, as we've heard in Sam's presentation. There's no need to be. It can happen. So let's think about more ways of doing that for our women and families. We're very nearly there, and I think we've also quite cleverly answered, everybody's asked their questions. As I say, this is a piece of work that we're going to return to. Funnily enough, you haven't brought up something that sort of hit me in the face when I looked at it for the first time, which we've got the infographic of the family in the middle, and for me it looks like each person leads to a different bit of the pathway, and I didn't like the way that happened, but nobody's actually brought that up, so I don't know if that's just the way visuals work for me. Because that was something we were thinking that we might change, but we'll have a play with it. We'll include, oh, Susan, you did see that. Thank you guys. So we want to try and do something with that.
Jenny, if I may, if you just put like an arc below the things, almost like the whole sort of family is in one boat, so that will, I guess that could potentially take that away.
Yeah, that's what we thought, if we did a sort of coloured thing. Oh, and Jenny, you've got your hand up.
Yeah, it's just to say it wasn't so much where they lead to, but I just didn't think the infographic of that picture was very diverse.
Oh, well, we chose that because it was the most diverse one we could come up with.
I think because it's just because it's a woman and a man and 2 children. Is
it a man though, or is it a woman in trousers?
I think most people would see that as a man, because it's a classic sign of a man that you see on a toilet door or whatever. But I don't know, maybe it's just me being sensitive to that, but I think it does look like a man and a woman to me, and 2 children. So it's a bit standard.
Okay, well, we'll have to think, because we were quite confident that we picked something that wasn't, but that's interesting feedback and valuable feedback. So we'll see what we can do with that as well. Thank you, Jenny. Okay, so it is time to finish. Thank you so much for being so interactive. Sometimes it's quite hard working virtually. Things can be a bit dry. And it certainly didn't feel like that today. It's felt like a fabulous day with lots of interaction and ideas. So thank you very much. Just to remind some of you that the next one is the 7th of October for the specialist teams specifically, and this is about the perinatal mental health data and access targets. Please, specialist teams, everybody, we want you all represented there, because we do need to talk about access targets. And for the whole group, the next big webinar is the 21st of October on safeguarding, and I would really ask you to encourage your safeguarding leads in your trust to attend, because we have a fantastic speaker on intrusive thoughts, and I know that that's something that is often very difficult to deal with within safeguarding in the perinatal period. So yeah, we're right on time. I can't quite believe we did that. That's amazing. And thank you so much for for such a great morning. Thank you. Okay, over and out. See you later. See you on the next one.